Oh, shit. Is alles afgehaald.
Oké, jongens, ik zit erin. Kunnen we samen? Of?
Mag jij daar zitten? Openen.
Maar mochten ze samen of niet?
Ja, maar we moeten denk ik eerst alle drie erin. En dan kunnen we misschien wel appen van...
Oh, mijn microfoon staat aan.
Wacht. Hoort je meteen praten? Ik moet even mijn mond houden. Ik ben wel zichtbaar, hè, Laar?
Okay, is everyone is in, I guess. We are with 96, so I guess 2 still need to come. It's my pleasure to introduce to you Richard Skolnik as the lecturer of this first masterclass. I guess Richard will introduce himself shortly, and I just put up a link in the chat box on his resume, his CV, so you can read over there. But Richard, I came to know Richard directly last year because he was one of the lecturers in the symposium we had because of the 10th edition of our Minor Global Health. And I asked him to come to Rotterdam to lecture at that symposium because he is the editor of the textbook Global Health 101, which we've been using since the start of this Minor Global Health. And as you can read from his biography, Richard has a long track in global health, not being a doctor himself, but knowing more about health than many doctors in the world, I guess. Worked at the World Bank, worked at PEPFAR, worked all over the world, worked at Washington University, George Washington University, and as well as at Yale University. And as I told you yesterday, the Coursera course Essential of Global Health through Yale University is also being made and run by Richard. So that being said, I would like to give the floor to Richard. Thank you very much, Richard, for lecturing our students in this all online Minor Global Health 2020, which makes it easier to invite international people. That's an advantage of a disadvantage, as we say here. But the floor is yours.
Jan, thank you. You can hear me okay, right?
Yes, I can.
Great. Well, thank you very much. I really appreciate the gracious invitation to meet all of you today. As Professor Nguyen knows, I have a real deep affection for the Netherlands and for all things Dutch. I've been visiting there for twice as long as any of you have been alive, and continue to have a real appreciation of the Netherlands. So it's, and I also have a real appreciation for the work that Dr. Nguyen has done, both as a physician and as a global health educator. I was honored to visit the Netherlands some months ago, and I'm honored to speak with you today. Let me begin in a kind of fun way, and then it'll get serious, more serious. Probably very few of you have had a chance to visit the American Southwest. And one of the beauties of the remote learning is that we can, as Professor Nguyen said, speak to each other from all over the world. Or there are now, Professor Nguyen will be amazed to know, 43,000 people from all over the world taking my Coursera course. By the end of this, you'll appreciate it if Professor Nguyen hasn't reminded you already that Skolnik is a pretty excitable guy, so you might be taking at least some acetaminophen before this is all over, but I'll do my best to try to prevent you from having too bad a headache. But let me begin in just by taking 1 minute of your time by showing you where I am, because it's almost, let's see, I got to do this again. Let me just, I'm going to share it now anyway. Give me one. Jan, somebody has to give me permission to share my screen because I have the slides. Forgive me if I call Professor Nguyen Jan. There we go. Thank you. So just, so I'm speaking to you from the American Southwest. I did spend over 40 years living in the suburbs of Washington, D.C., but I'm speaking with you from the American Southwest in the state of New Mexico, which in most respects is the exact opposite geographically of the Netherlands. And you can all see this now, right? You can all see my screen, right? And you're looking here This is literally a 10-minute walk from my house, and you're looking at a gorge on the Rio Grande River. Those of you who've read about the Rio Grande might believe that it's really grand. It's actually not that grand at all. And of course, thanks to climate change, it's getting less grand all the time. But I'm speaking with you from a home that's about 2,000 meters up, 10 minutes walk from this canyon on the Rio Grande. We're high and we're dry. We have beautiful weather during the day and cool evenings. Let me just show you. And then about 20 minutes from here, when you come to visit us, this is the scene of the river a little bit further away. It's about 20 minutes from here. The only green we have is along the river. We don't really have any more. And finally, to put us on a happy note as we begin, unlike the Netherlands, we get very little rain, and every time it rains, the sun shines immediately. And so what we get is rainbow after rainbow. And this is actually just around the corner from my home. So now that I've introduced you to where I am, and you're all welcome to come when the circumstances permit, I gotta get this down, there we go. 2 seconds. Sorry, 2 seconds. Two seconds. Why do I do this? There we go. Okay. And Jan, everybody can hear me okay, right? And so Professor Nguyen has kindly invited me really today to speak about 3 subjects. And what I would propose to do is handle them in 3 little modules. He's asked me first to give a kind of introduction to global health, what it is, why it's important, some of the progress that's been made, and some of what we can learn from this. And then in addition, speak a little bit about what kind of work people might do in global health, some of the areas of work you might consider. And finally, I want to make some suggestions, if not pleas, about what we as concerned citizens need to do to try to make the world a better place, even as you go through school, given not only what we face today, but the more general issues related to global health. And then why don't we take a 5 or 6 minute break and then come back. And following Dr. Nguyen's second question, I'm going to make some comments about COVID-19, but not about the virus itself so much as about COVID-19 as a reflection of all things global health. In some respects, wonderfully, if you don't mind my saying so, and in some respects, horribly, COVID-19 is the perfect excuse for why it's the perfect opportunity for seeing the importance of global health, and each of the critical global health issues all wound up into kind of one framework. And then take another 3-minute break and finally end as Professor Nguyen asked me to, not because I like talking about myself so much, but by commenting a little bit about my own journey through global health, but really focusing on 2 things I've learned. One is the lessons I've learned in terms of pursuing a career in global health. And the second will be some of the most important lessons I've learned technically that I would want to encourage you to think about as you go through your journey. What I'd like to do is take the questions in 3 parts. Give part 1, and then open it up for questions. Take a 3-minute break, take a 5-minute break, comment on COVID-19, take some questions, take the last 3-minute break, and then come back, talk a little bit about my own journey, and then take some questions there. I think otherwise it would just get too long and too overwhelming. But if you have any questions at any time, please don't hesitate to just shout them out. I can't see the chat box so easily. So just shout them out.
I will moderate the chat box, Richard.
Okay,
so
and
I will keep
so
an eye on
if
it.
you have any questions, perhaps what you'd like to do is put them in the chat box, and then Professor Nguyen could be kind enough to interrupt me.
Yeah,
and otherwise what we'll do is we'll take them at the end. So let's begin with part 1. Let me give you some of my introductory thoughts about global health. One of my favorite phrases, and I don't know if I invented this or I borrowed it or modified it from others, is what you see on the screen now, and that is that the health of anyone, anywhere, is the health of everyone, everywhere. I should have some commas in there, I will later. But I want to encourage you to think about this. I want to encourage you to remember it. You probably wouldn't be taking Professor Nguyen's course if you didn't already believe it. But I think this phrase is as central to anything in global health as we can find. And indeed, one day when I tweeted it out, my nephew was very proud of me because within an hour, there were something like 13,000 people who had seen it and thousands who had retweeted it. So I want to encourage you to keep this, why is it, okay, there we go. Okay, consistent with what Professor Nguyen has asked, I hope by the time you leave the session, and 2.5 hours or a little plus, that you will be a little bit different than you are now in thinking about your ability to talk about a range of global health concerns, why both health and global health are important, to comment more than you can now on some of the most important areas of progress in global health, as well as some of the key issues in the unfinished global health agenda, to think about and be able to articulate COVID-19 in a way as a kind of reflection of all things global health, and finally to have a better sense of and be able to think more clearly for yourself and articulate better some of the possibilities for working in global health as you go through your career. I want to start, and I know you know a lot, so don't take this personally, but I want to start by ensuring that we're on a common foundation. So let me start with some definitions. One is, what is health? And as many of you will know already, the World Health Organization defines health as a state of complete physical, mental, and social well-being. It's not merely the absence of disease or not merely the absence of infirmity or disability, but what we're really looking for is a complete state of physical, mental, and social well-being. And the aims of societies, in many respects, should be, of course, to enable people to achieve that complete sense of physical, mental, and social well-being in continuous ways, at least cost, and in ways that are very fair. So when it comes to global health, I'm going to discourage you from spending much time thinking about definitions. I mean, I hope Professor Nguyen doesn't mind, but in some respects, global health is what you want it to be. And for me, that's totally okay. My friends have written articles trying to define global health. Occasionally, they argue about what the definition should be. But I think it's easiest to think about something like the areas of concern for global health. And I want to suggest to you that when I think about global health, I think about the health of populations in a global context in 3 or 4 areas. I'm going to start in the bottom right. So the one area that's traditionally been the most commonly defined area of global health is the health of people, especially poor and marginalized people in low and middle income countries. Once upon a time, it was called international health. Later, people thought that this was patronizing. We're now living in a world we understand, except I'm sorry to say my own country, where we really need to cooperate across countries, where we need to learn from each other, where we need to constantly be exchanging ideas and possibilities. And therefore, the term shifted to global health about 20 some years ago. But it's certainly true that in many regards, the health of people, especially poor and marginalized people in low and middle income countries, remains at the center of our concerns for global health. But it's not the only one. In addition to that, as we can see with SARS and MERS and Ebola and COVID-19 and antimicrobial resistance, on which Professor Nguyen is a great authority, what we know is that there the health of anyone anywhere is the health of everyone everywhere. Diseases don't respect boundaries. Malaria and mosquitoes don't know the difference between Congo, Brazzaville, and the Democratic Republic of the Congo. And therefore, we know there are a wide range of issues that are interdependent. The world, no country can go it alone. Diseases don't respect boundaries. We're all in this together. Certainly you in Europe understand that far better than most Americans do not understand it. But another area of concern is these areas that are interdependent. It used to be that we worried mostly about infectious diseases, but we certainly know that when we think as well about emerging and re-emerging diseases, infectious diseases more generally, antimicrobial resistance, climate change, and a range of other matters, they're bigger than any country can think about. They're bigger than any country can handle. They affect all of us. We're all in this together, and therefore that's another area of concern. A third is lessons that can be shared. I'm always astounded in my own country, which I'm going to beat up on a little bit if you don't mind, at how few people have traveled, how few people have taken a good look at what other countries do, and therefore how relatively ignorant we are of what we should be learning from other countries in terms, for example, of refining America's health system. When President Obama was the president and people were thinking hard about the directions for American healthcare, people who were global in perspective understood that the two countries from which we probably had the most to learn were the Netherlands and Switzerland, in terms of where the US is, where it might go, and what might be feasible. And yet there were a wide range of people in the United States deeply involved in healthcare reform who really, to be honest, knew almost nothing about the Dutch healthcare system. They knew almost nothing about the Swiss healthcare system. And then when it came to savings plans, they really didn't know very much either about Singapore, whose health insurance scheme is largely based on family savings plans. And they certainly didn't understand that the Germans had in the 1860s created with the creation of modern Germany an approach to universal healthcare that's gone on since then. So I want to suggest to you that if we're to make progress as a global society, we have to learn from each other. And I want to suggest to you as well that this is a central feature of global health. One of the great gurus of global health, Srinath Reddy, was kind enough to speak for me when I was at Yale. And students asked him whether or not there would be jobs in the future. And Dr. Reddy, who's one of the three smartest people I know and probably the most articulate, said there will be jobs and there will be global health work in the future, but the way the work gets done will be done differently. Once upon a time, there were people in high-income countries who knew more than people in low-income countries and often led the work. But increasingly, and today we're there, in my view, we're living in a world that's interdependent, where there's talent in all countries, and where those of us who work in global health appreciate that if we're to help anyone make progress, we need to be sure we learn from each other all the time. And the last is areas requiring cooperative action. A good example of this would be AIDS treatment in low-income countries with high prevalence. All of the modeling work that's been done suggests that if you have a relatively poor country with a high rate of prevalence of HIV, there's no time in the near future, even if their economy booms, even if they make really hard efforts at raising taxes, there's no time in the near future when they will be able to finance the AIDS treatment of their population themselves. Do we care about that? Do we see this as a global concern? And if so, how can we act cooperatively? Vaccines, one of the great success stories collectively has been the development of the Global Alliance for Vaccines and Immunization. If we want to try to enable the development of new vaccines, new formulations of vaccines, vaccines that are more cost effective, vaccines that we can help relatively poorer countries to finance, we need to work together. If we focus only on antimicrobial resistance on pig farms in central United States and don't share with Professor Nguyen and others what we're learning about resistance to malaria, resistance to HIV, resistance to tuberculosis, resistance to varying antibiotics, we're going to be, as we say in English, completely cooked. We'll never get anywhere. So I want to suggest to you that there are many definitions of global health. Again, I would discourage you from worrying about them, but I think almost everyone would agree that these are areas where global health is centrally concerned. And again, please don't hesitate to interrupt me at any time. You know why health is important, but I want to reiterate that, and the reason I do this is because, as Professor Nguyen knows well, and I'm much older than him, but when I was your age, health was regarded as a consumption good. Economists were just beginning to think about health, nutrition, and education as investments. The human capital school of economics was just beginning to be born. And I was very fortunate in being able to study with Frederick Harbison, who was one of the great pioneers of human capital economics, and by the way, whose son became my close colleague at the World Bank, which was very touching. And when I joined the World Bank, in fact, in my interview reports, the interviewers commented, this young man seems to be all about human capital. He seems to be all about health, nutrition, education, family planning, social well-being. Is there really a place for him at the World Bank in 1976, where at the time, the focus continued to be on infrastructure, and there were very few people like myself. So today you all will understand this well, but don't forget that it wasn't that long ago that people didn't understand this. And there continue to be lots of ministers of finance in a number of countries, I would say, who still don't really see this, as well as lots of other people. So let me say, first of all, obviously health is central to overall well-being. If WHO's definition is complete well-being in a variety of ways, well, health is clearly central. Secondly, there's a remarkable link between health and nutrition, as you know. As we'll talk about later, and as you know, nutrition is fundamental to human health, to human physical and cognitive development, to whether or not you reach your full biological and intellectual potential. And there's a complete interaction between health and nutrition. If you're not healthy, you can't take in nutrition as you should. If you're poorly nourished, you're not going to be healthy. And yet not everybody appreciates the central place of nutrition to human well-being. And of course, today, it's not just undernutrition. Today, it's undernutrition and it's overweight and obesity as well. I can't stress enough, and every study has shown, of course, that because health is so important to children's development, both physically and intellectually, there are many children in the world today who are not in a position to learn well because they've been unhealthy and they've been undernourished. They will not be able to, they'll start school late, they won't succeed in school, they'll leave school early, and their prospects for becoming productive adults is thereby substantially diminished. We know, of course, that there are enormous links between health, illness, and poverty. In many respects, there'll be less in a place like the Netherlands than the United States, but in the US and in India, for example, the leading cause of falling into poverty is getting sick. If you get sick and the costs of healthcare are very high and you're not insured for them, it's almost guaranteed that you'll have to dispose of assets to try to pay for your care, and you'll fall into poverty. When I worked on India for 15 years, we did a study with our Indian friends, and it showed again, that the leading cause of falling into poverty, which often lasted for a long time, was getting sick, okay? Which again highlights, as you know, the importance of ensuring universal health care in all countries. Countries spend a lot of money on health. The Dutch probably spend 8 or 9% of their national product on health. We in the United States spend about 19%. I think in Europe it goes as high as around 12% in Switzerland. If you're spending 10, 11, 12% of your national product on health, it means that's money that's not going for other things. And it highlights the importance of trying to ensure that you get the most for every guilder and every euro that you spend. And finally, there's this important link between health and development. You all will understand it well. But if I said how many of you would be willing to invest in a country with high rates of malaria, HIV, and HIV, you'd probably say, I'd rather invest in a country that has low rates of malaria, low rates of HIV, and a much healthier population. And there are many, many ways in which we know there's this remarkable link between health on the one hand and development on the other. And I think if you're a student of development, you can see that no country, except the oil exporting countries of the Gulf, no country has been able to achieve high levels of social and economic development without investing heavily in nutrition, in health, and in education. And that's just been the history of modern times. And those relatively poorer countries that, and there's also a number of outliers, a number of relatively poorer countries that have important lessons for how you can achieve high levels of health, nutrition, and education, even when you're still relatively poor. And for that, you can look at the history of China after the revolution. You can look at Sri Lanka. You can look at Cuba. You can look at Southwestern and now Southeastern India as well. Again, please don't hesitate to raise questions at any time. So why is global health so important? I've alluded to it already. One, as we've said, diseases don't respect boundaries. Two is, in Europe, you're more sensitive to ethical issues than people in the United States are. But if I said to you, 5 million under 5 children a year continue to die every year, you in the Netherlands would say that's not okay. As Dutch people, that's our problem as well. When we look at the relationship between health, poverty, and inequity, you in Europe would almost certainly say the differences between the way we live and the way people in poorest countries of Asia and Africa live isn't fair, it's not okay. And we have a collective responsibility to try to help address that. And so there are a range of ethical issues that arise when we're thinking about global health. Again, back to the health development link, it's hard to understand how the Democratic Republic of Congo, Liberia, or Guatemala or El Salvador can achieve high levels of economic and social development if their people aren't healthy, when health is so central to being well nourished, to going to school, to succeeding in school, and to becoming a productive adult. And I want to remind you I want to encourage you to always think about the end. So what's the end? You know, when we think about development, what are we after? I want to encourage Professor Nguyen to expose you at least a little to the writings of Amartya Sen, who's a Nobel Prize-winning economist. Professor Sen wrote a book called Development is Freedom. He's a great man I've had the opportunity to meet, but his books are at least this thick. If you think my book is thick, multiply it by 3 to get Professor Sen's book. And Professor Sen appreciated when I told him in my own book, I summarized his book in one line, which he actually accepted, which is a great honor coming from a Nobel Prize-winning economist. So if you don't have the time to read Development is Freedom, I will summarize by saying Professor Sen suggests that the end game of development is the creation of societies which enables everyone in the fairest possible ways to be all that they can be. The creation of societies which enables everyone in the fairest possible ways to be all that they can be. those of you in Europe will understand this more easily than many others, but I want to encourage you to think about that as the end game for development. If that's what we're after, then say to yourself, what's the place of health? What's the place of nutrition in trying to enable everyone, no matter who they are, no matter where they are, to live to the maximum of their capability in the fairest possible ways. In addition to that, as we talked about, there's a range of public goods that relate to health. Climate change has an enormous relationship with health. No country alone can take on climate change. Antimicrobial resistance is incredibly important. No country alone can take on that. No country alone, although the United States announced today that it's going to go alone on COVID-19 vaccines, if it turns out, of course, that the Oxford vaccine is better than the Moderna vaccine, you all will have access to the Oxford vaccine, and we will not, or at least not for some time. A range of public health emergencies also are global public goods. So these are really central to global health, and global health is central to them. And working together to try to address them is important. So I think global health is a subset of health. We shouldn't think of it as different. It's a subset of public health. So we need to understand why health and public health are important, but then also understand why the globalization of these is so important as well. Now I want to take just a couple of seconds to say, you've obviously made the choice to study global health. But as I mentioned to the students in the Netherlands when Professor Nguyen kindly invited me there some months ago, I think everybody should study global health. And in fact, I was lucky enough to go to Yale University as an undergrad, and I'm working with some of my classmates to encourage Yale to try to ensure that no one can leave Yale with an undergraduate degree without being literate in global health. And I want to suggest to you that this is important, as the former Canadian health minister said, because studying global health helps us, as well as studying anything else, to understand what she called our common humanity, our shared destiny, and our interconnectedness. So I'm happy to see you in this course, and I think it's critical for you, if you are to be enlightened citizens, to study global health and to gain some of the perspectives that you can get. I also want to suggest to you that there's real value in studying global health because, especially for those in the sciences and in medicine, there's a tendency, or there was historically a tendency, to see these as technical fields. But I want to suggest to you that whether you're studying the sciences or medicine or art or literature, it doesn't really matter. I want to suggest to you that gaining the perspectives noted here will make you a much more enlightened citizen, a much more literate citizen, and a citizen with a perspective that allows you much better than otherwise to be contributing to making the world a better place. I think by understanding the burden of disease, by understanding the underlying social and other determinants of health and risk factors, by seeing the world and the more globally and the challenges we face more globally, by putting them in an ethical perspective, by linking them with social and economic issues, and by taking a multidisciplinary approach to everything that you do, I think you will come out as a better person, again, better able to contribute to society. And I can't think of a better topic for helping to change your perspectives in those directions than the study of global health. And studying global health will also enable you to have a greater appreciation of where people are coming from and the backgrounds they bring to life, as well as to whether or not they're sick or they're healthy. The more we learn about other people, I think the more we bring humility to the table, and the more important that is. I love everyone in the world, as Professor Nguyen knows, But I'm going to make a critical comment about both my own country and the Swedes. I think the Swedish approach to COVID-19 was taken up partly because the Swedes have a very deep-seated sense that they're the best, that the way they do things is the best, that their approach to society is the best, that their social safety net is the best, and that they know a lot more than other people. And I think that lack of humility led the Swedes to take an approach to COVID-19 that was based on a series of either false premises or at least premises that were not yet scientifically proven. I think the Swedes are now at great risk of waking up 10 years from now and finding out that a number of the people who were infected, who would not have been infected if they'd take the New Zealand approach, will be walking around with after effects of COVID-19, including possible heart disease, possible vascular disease, possible neurological effects, et cetera. We don't yet know the extent to which COVID-19 infection alone, even in the absence of symptoms, can produce later problems. And I want to suggest to you that humility should be the order of the day. We need to be incredibly humble. This is a terrible shortcoming of my own country, made worse by the present leadership. And it risks literally burying my own country completely. I think when you study global health, even though it's way beyond the technical, you'll gain an additional appreciation for some technical issues. When you see HIV in the Netherlands, it's one thing. When you see it in Kenya or Tanzania or Uganda or Rwanda, it's really another. And you'll be greatly enlightened through the study of global health. And I think the other thing that happens is it's certainly true that in the last 2 or 3 decades, global health has become a movement. We all need something to live for. We all need to take strength from some commitment to something besides ourselves. And as you would expect me to say, I can't think of a better arena than global health as a focus for your future attention. So let me now that we talked a little bit about what public health and global health are, how you might see it, why I'm so happy that you're studying global health, and how I hope you'll be changed for the better by that study. Let me just talk about a couple of specific global health issues in hopes of encouraging and inspiring you. So look, there's no issue. On the one hand, there's been an enormous amount of progress in global health. Never before have so many people in the world lived for so long. Life expectancy globally has increased by almost 40%, over the last 30 years. Never before have so few young children died. When I started working in global health, there were over 20 million under 5 children in the world who died every year. As we'll talk about, there's 5 million now. Never before have so few women died of pregnancy-related death. And at the same time, although COVID-19 hasn't helped, we're also looking at a world which has come close to eradicating polio and guinea worm. And there have been a range of areas beyond these in which there's really been progress. HIV infections, although still numerous, have come down. AIDS-related deaths have come down. Tuberculosis-related deaths have come down. So almost everywhere you look in global health, and when vaccine preventable disease has been an enormous, enormous success. When I wrote my first edition in 2007, measles was the 3rd leading cause of death of under 5 children worldwide. And I think now it's the 31st leading cause of children under 5 in the world. On the other hand, you're taking global health and you're thrilled to be able to learn from a person of the talents and commitment of Professor Nguyen and his colleagues, because there's a large, unacceptable, unethical, unfinished agenda. Even though there's been an enormous amount of progress, there's still more than 5 million under 5 children who die every year in the world, and almost all of those deaths are needless. This is the equivalent of something like 15,000 under 5 children who die every day in the world. In addition to that, somewhere between a third and half of these deaths relate to children being undernourished. There's whole parts of the world, like the entire northern tier of India, in which somewhere between a third and half of the children are undernourished. These children get sicker and die more, for example, of measles, pneumonia, and diarrhea, than they wouldn't die and wouldn't be so sick if they were better nourished. And although there's been progress in maternal mortality, there's still 300,000 women who die of pregnancy-related death every year, and there's millions of women who suffer maternal morbidities every year. And even though there's been progress, and Professor Nguyen knows I used to work extremely closely with the KNCV, the Dutch TB agency, and have wonderful friends still from there. They've done great work. There's still about more than 1 million TB deaths a year, more than 1 million AIDS deaths a year, more than 600,000 malaria deaths, despite the progress. And there's 8 or 9 million people every year who get infected with active tuberculosis disease. This cannot be okay. And as you know, there's a train running down the tracks at very high speed with more and more and more people globally, including in low-income countries, who are getting cardiovascular disease, dementia, diabetes, obesity, and overweight. So there's been an enormous amount of progress, and yet there's a gigantic unfinished agenda that calls out for good people like you to become involved to make the world a better and better place. Just very quickly, to probe just a few other things that will inspire you, some of which you'll read about in the book. As Professor Nguyen will tell you, the greatest story of all is smallpox. Everything that's being done today in some respects is based on the lessons of smallpox eradication. Only one human disease has ever been eradicated, that's smallpox. Only one animal disease has ever been eradicated, that's rinderpest, which is related to measles. And I want to encourage you to take a look at the book called House on Fire by Bill Foege. As Professor Nguyen knows, Bill Foege is one of the great public health heroes. And at the end of the book, Professor Foege summarizes everything he's learned from one of the great careers in global health. And I can't recommend enough to you that the whole book, which is very brief, it's only 100 pages, but especially the end. But smallpox is central. You should learn about how the world did this. You should learn about the remarkable managerial strengths of a campaign which initially set out to immunize everyone in the world. They realized this was a hopeless, impossible task, and they moved therefore to a different approach, which was basically on identifying cases, surrounding the area where there were cases, immunizing everybody within that area, and then going on to the next area. And this is a dramatic and wonderful story I can't recommend enough. It provides some lessons that remain absolutely central to the heart of everyone in global health. Childhood vaccines, despite vaccine hesitancy today, this is really a great story. And this is a story whose wonderfulness has been enhanced by global cooperation. In the last 20 some years, the world has worked together in a different way than it had earlier. Earlier, it had worked through UNICEF. Now it works much more through the Global Alliance for Vaccines and Immunization. There's been an enormous amount of progress, in increasing coverage against with the 6 basic antigens, but there's also been enormous progress in developing new vaccines for pneumococcus, for rotavirus, for HPV, for meningitis, for getting out these vaccines much more. And if you look at these declines in under 5 child mortality, they are certainly partly a reflection from this enormous progress in in getting vaccines out to the children who needed them most. And I encourage you to look at that story. There's still a big agenda in malaria, but in the last decade or so, there's been substantial treatment in malaria. As Professor Nguyen can tell you, this progress is always hanging by a thin thread, as we would say in Dutch, because resistance, the minute you begin treating with a new drug like artemisinin combination therapy, resistance begins to form to that drug. But there's been important progress. There are more and more countries in which they're on the verge of elimination from their country. And deaths are substantially down, cases are down. We know what to do, but there's this really challenging issue of resistance to the drug that we need to stay on top of all the time. When I was your age, no one talked about universal health coverage in poor countries. People thought the Dutch could have universal health coverage, the British could have universal health coverage, the Norwegians could have this, but they regarded this as a luxury for rich countries. This is no longer the case. Everyone now sees universal health coverage as absolutely central, and every country in the world, except my own, I'm sorry to say, has a commitment, even if they're poor, to achieving universal health coverage as rapidly as possible, even if the package of services is basic. I want to encourage you to study what Thailand did, because Thailand probably has led the middle income world in developing a very thoughtful, ethically oriented approach to ensuring all of its people and trying to enable better health that way. And in the low income countries, you might not like the authoritarianism of Rwanda's government or Rwanda's leader, but I want to encourage you to look hard at what Rwanda has done. It really has made dramatic improvements in improving the health of its people, largely by focusing on outcomes, encouraging those outcomes in the system through a pay-for-performance system, and focusing on what we would call the best buys, those areas that will buy the best, most health in very cost-efficient ways, and then linking this with community-based health insurance. Despite being a relatively poor country, they've made really important progress, and I think Rwanda has some important lessons that I encourage you to study when you think about relatively poorer countries. I'm not going to say much. I'm sure Professor Nguyen and others will remind you that in some respects, the world has created an organizing principle for encouraging better health, and that's the Sustainable Development Goals. I want to suggest to you that you need to know what they are. You need to know what the Millennium Development Goals were before. I don't get so excited about this because planning is easy, but implementing is difficult. So I'm happy to see these goals and these targets as an inspiration to the world and an inspiration to individual countries. But at the end of the day, what really matters is the ability of individual countries, sometimes with the help of their friends, to implement different programs effectively. Let me end with just a couple of last comments. For those of you who are interested in studying medicine and being clinicians, there's no issue. This is a wonderful pathway to the possibility of your working in global health. But I want to remind you that global health is completely interdisciplinary, and there are opportunities to work in global health in a wide variety of ways. This is my friend Ellen Ogden, who has headed the United States' work on worldwide polio for 15 or 16 years. I think of Ellen as a global health hero and as a global health saint. She has a master's degree from Tulane University. She got first interested in this when she was a US Peace Corps worker in Papua New Guinea. She is as wonderful and as committed a person as any. She's not a clinician, but she's widely admired and appreciated by everyone. This is a picture of Ellen giving a polio vaccine on a outdoor campaign in India. This is Poonam Mutreja, who developed a not-for-profit in India that focuses on the health and well-being primarily of India's women. She has had a wide career, always working on development, always working on health, always working on women's health. She studied public affairs at the Kennedy School at Harvard. Here's my friend Pop Guy. He's the head of one of the US's most prominent not-for-profit health consulting groups called IntraHealth. He's actually did a business degree. He then worked for the Peace Corps in his own country and in Benin, and later decided he could parlay this he could himself become more involved in development work. He went off and got a Master of Business Administration at UCLA and became really an important leader and pioneer in global health work, primarily in Africa. This is my friend Lisa Russell. I hope you'll have a chance to see some of her films. She did she studied anthropology, which is very useful for global health. I think we all need to be anthropologists at heart if we're going to be successful in global health. She did an MPH at Columbia University, a Master of Public Health degree, and then turned to film, which she really learned on her own. She's an award-winning filmmaker. She's made wonderful films on global health and wonderful films on women and women's life as well. She's actually now in Kenya making a range of additional films. I had the great pleasure of seeing my friend David Heyman when I was in Rotterdam at Professor Nguyen's invitation some months ago. If you want to be a clinician public health specialist, Professor Nguyen is an excellent example of what you might do with your life. But the height of heights in some respects was attained by our good friend David Heyman, who at one time led the world's work on infectious diseases at the World Health Organization, and who many of you can read more about in my book. David is now deeply involved in public health in the United Kingdom and the chair of the board of what was Public Health England until the Brits dissolved it recently. But David is also now a professor at the London School of Hygiene and Tropical Medicine. Lastly, let me say, whatever path you want, I want to suggest to you that as a concerned citizen, these are actions that I hope you'll all take, especially in a world where we're living through a pandemic. Get better informed, think globally, advocate for better action, push global cooperation, and vote for people, wherever you're from, wherever you live, who actually understand something about global health, who understand our interconnectedness across countries, who understand the importance of taking ethical, cost-effective approaches based on evidence to making the world a better place. We have a lot of leaders these days who do not think and act those ways. It's not just Lukashenko in Belarus, it's Bolsonaro, it's Duterte in the Philippines, which is as you'll learn later, the country I first got started in. It's the President of the United States. It's now more important than ever that as enlightened citizens, you take some of these approaches. So let me end this part of the chat by saying two last things. The Norwegians asked me to speak recently. They used my book and asked me, how should they use the book? Professor Nguyen and his colleagues will have their thoughts. But I want to suggest to you that the real value of the book is helping you to gain perspective. When you finish Professor Nguyen's course, what I hope you'll be is someone who has a series of eyeglasses. You have a global health perspective in a broader and deeper way than before. You'll have an equity perspective broader and deeper than you did before. You'll have a development perspective closer what Professor Sen said that you might not have had before. And you also have frameworks and concepts for remembering that in poor countries, you're trying to bury old people instead of young people, make the transition as fast as possible and do it in ethical, fair, doable, and sustainable ways. And then in the Netherlands, what you're trying to do is ensure everybody lives as long and healthy as possible and then dies in their sleep, and that you can achieve that at least cost in ethical, fair, doable, and sustainable ways. And finally, when you finish using the book, you'll look at every problem with Skolnik's 5 questions in mind. When I'm looking at this society, what's the problem? Who gets it? Why do they get it? Why is it important? And what does the best available evidence can be done in cost-effective, fair, doable, and sustainable ways? So my hope, if Professor Nguyen was to judge my work as a global health practitioner, teacher, and author, I hope he would say, let's see the extent to which Skolnik's book helps my students to come out with eyeglasses on that enable them to see the world in a new kind of reality. And that is with these concepts and frameworks that we talked about before. Why don't I stop there, Jan? And let me get out of this. And with your permission, why don't we take a 5-minute break right now at the hour mark, because I'm an old guy, and then I'll come back. We'll take questions on this and then turn to COVID-19 as a reflection of all things global health. Will that be okay with you, Jan?
Yeah, that will be fine for me. So
I'll come back in
5:05.
exactly 5 minutes while the students collect their questions, and then we'll begin to take them on this part of our conversation. And we're done with that. We'll move on to COVID, some remarks I have on COVID-19, okay?
Okay, thank you very much.
I'll be back in exactly 5 minutes.
Okay, will do.
Talk among yourselves. Even less than 5. Miss Bergen, if I might, Lotavan, if I might ask, is the university completely on remote schooling? Are all the classes remote right now?
You mean online? Or?
Yeah, are they all online?
No, I think it depends which minor you choose.
I see, okay. So some courses are actually being conducted physically.
Yes.
I see.
Sure.
And where are you in your program of studies? What year are you in?
We are in third year.
You're all in third year.
Yeah, so everyone chooses a minor in their third year.
Right. So this is part, you're all in the minor in global health, as they call it in there,
Yes.
right?
Yes, that's true.
And are you studying to be what is your major?
I'm studying medicine.
Excellent.
But as a minor, you can choose a minor from every study. So maybe others
Right.
do a different study.
So since some of your courses are physical, you're all in Rotterdam.
Yes,
But
yes, we are.
it doesn't matter. It's such a small country. You can get there.
Yeah.
You can get there in 10 minutes, no matter where you are anyway, right?
Yeah, that's true.
So I was saying to, so the state in which I'm living is quite interesting. It's 600 kilometers north-south by 600 kilometers east-west, and we only have 2 million people. So when I last visited the Netherlands, I was talking with my Dutch friends about how the Netherlands, of course, which is one of the most densely populated places in the world, is something like 100 times more densely populated than where I live now. And where I live now is also quite interesting socially, because the majority of the population are either descended from Native Americans. We have the largest share of Native Americans in the population, except in Alaska, or they're historic Hispanics. They're people whose families have been here since this belonged to Spain 400 years ago. So it's a very interesting population. And I hope if COVID-19 will go away, that I can help Professor Nguyen to twin Erasmus with our Indian Health Service, so that some of your students could spend the summer in New Mexico working with Native Americans, which is completely, and as I was saying, Jan, that I'm hoping that if things will calm down, I can honor my hope to twin you with the Indian Health Service of the US, which also represents all things global health. We have in our state probably a third of our Native American population, which does not have access to safe drinking water, if you can believe it. I mean, it's really remarkable, but an extremely rich, very interesting culture with remarkable artistic traditions. I'm really hoping that some of our Dutch friends will be able to come. I was saying, Jan, I was asking one of your students about if you're all online or not, and then talking about how the Netherlands is about 100 times more densely populated than where I live now, but also my hope that we'll be able to get some of you to come and visit. But Jan, I'm complete. May I make one comment about the Coursera course? Don't worry when it says start date. There's no such thing anymore as a start date in Coursera. The start date is whenever you want. Once upon a time in Coursera, there were every month, 1 day, 1 week to enroll. This is no longer the case. You can enroll in a Coursera course any time that you want. Jan, I'm completely, I hope you don't mind my referring to you occasionally as Jan rather than Dr. or Professor Nguyen.
Please call me on.
It's with affection.
No.
I won't tell you what people call me. I'm completely at your disposal.
Yeah, thanks. So no, I just posted this about the Coursera course because we use now Coursera for Campus, so that then the students can access it through Erasmus University website and get a certificate for free. This is one of the Coursera initiatives because of COVID.
Right.
So we participate in that, but it depends on when you register, and then it says you have a start date X, Y, Z, depending on when you've registered. But just to be clear, indeed, you can just start and finish whenever you would like to do that, and do it at your own pace.
And what I can do, Jan, I see that Arya Baban has asked if you can get a certificate if you're on the free plan.
Yeah,
Coursera had waived the payment before, but I
no,
will
but
check.
that's being done by a university.
Okay.
So Coursera for Campus is a Coursera initiative, and Erasmus University is part of the Coursera consortium, and they joined this Coursera for Campus so that students who are with participating universities like Erasmus University can do all Coursera courses they want until the end of December and get all the certificates for free.
And remarkably, even if somewhat sadly encouraged by COVID-19, since March of 2020, the enrollment in my course has grown by more than 1,000 a week, if you can believe it.
Yeah, I can imagine.
And about 65% of the learners are female, which is way above the Coursera average. And 55% are in Asia or Africa, which is above the average for non-technical. So, I hope that it can be useful to you and your colleagues. I'm all yours. Any questions that you'd like me to take, I'm completely at your disposal.
Yeah, so I know we have to check. So there's one question from Chris Luxa. He says, do you have any ideas or plans on how to make global health more known to the common public?
So I'm not sure of plans per se, but I do think there continue to be activities and efforts which are making global health more known to the public. And these continue to evolve around both people and events. So on the one hand, you have people and actors, like the Gates Foundation, which only began about 25 years ago, and the continual appearances of Bill Gates, which are helping to remind people about the importance of global health. The same goes, of course, for Bill Gates and his wife. Then there are even people like Michael Bloomberg, the former mayor of New York, who's giving lots of money away to organizations like Resolve to Save Lives, which is not only working on technical issues, but also engaging in advocacy work. And then, of course, and then you have the regular groups, WHO, UNICEF, World Food Program, and others, which, especially brought out by some of what's going on, are advocating more and more. And then finally, within universities worldwide, global health really has become a movement. There's one university I know where 600 students wrote a petition to the president demanding that the university create a global health program. So I don't think there's anybody in an organized way necessarily who's trying to push the world toward greater global health literacy, but I think there are a substantial number of actors who are doing that. And at the same time, however sad, certainly COVID-19 is awakening many people to some of the points that I made in my comments, to the interconnectedness of the world, to how we're all in this together, to the importance of working together, and the importance of having a greater and more global perspective on health than otherwise. Again, I think in Europe, this is a much easier, helping people to get to that point in Europe. In Australia and New Zealand is much easier than in the United States, which remains a large, isolated country that's completely divided right now between people who see us as sharing the ideals of the Dutch people and people who want us to be like we were in 1920. And so that's working against this. And that's also true in a few other countries. So I think there's no coordinated movement, but there's a movement and more and more and more. If you knew how many people used my book, you would be astounded. And how many students are studying global health worldwide, it's really impressive. Let me stop there, Jan, and see if you have another question.
So there's one other question by Bade. He asks, why do you think that it is so hard to implement those goals? Is it because other countries or people do not think they have anything to gain from helping or investing?
So, you know, when we're thinking about the Sustainable Development Goals, let's say, or enabling better health, and I'll talk about this later as well. You know, poor countries are poor for a reason. And one of the reasons is because they don't have much money, their institutions are weak, they don't have the trained manpower they need to work effectively in a number of areas, and many of their populations are not so well educated and so receptive to some kinds of changes, sometimes even when they're in their own interests. Working on South Korea or Singapore or the Netherlands would be easy. For those countries, change is a question of political will. If the Dutch decide they want to change their health system, it's a question of political will, not a question of whether or not there are enough well-trained, competent Dutch people who can administer the changes. So, two things. One is the nature of the development business is enabling change, which often is not desired by people. You know, people who smoke don't necessarily want to stop. People who breastfeed their babies for only 3 months may think that's what God or the community wants them to do. It was very difficult earlier to help countries take AIDS seriously and act on it effectively. So that's difficult. One difficulty is change is the name of the game. But the second difficulty is the countries themselves have profound institutional weaknesses and often cannot execute all that they need to themselves. So first, their own institutions need strengthening, and second, often they need help from the outside. And this is really what makes it so tough. Let me end by saying planning is easy. You know, if you ask me to design tomorrow a plan for my friends in Liberia to reduce maternal mortality, with my friends in Liberia, we could design a plan that everybody would agree made perfectly good sense. But in Liberia, which is quite poor, institutionally very weak, had a civil war, lost many of its most talented people, suffered through Ebola, and is now suffering through COVID-19. Trying to implement that plan, it is going to be extraordinarily difficult. So it's just in the nature of the game. And I want to encourage you to always focus not on planning, not on inputs, not on outputs, but as we'll talk about, on outcomes. What will it really take in Liberia to reduce maternal deaths? Jan, please go ahead.
Okay, so there was another question by Mitte Tahar. Which parties are nationally and internationally the most important to make sure the goals turn into realizable implementations?
So, you know, if we're thinking about the Sustainable Development Goals, I mean, there's no substitute for action by individual countries. You know, if the Rwandans don't want to implement or can't implement a vaccine program, it's not going to happen, no matter what you and I want to do. So the first thing we have to realize is the most important parties are always families, communities, societies, and countries. Secondly, some of these countries are not on their own able to implement all even that they would like by themselves. And I think what you'll see today is, you know, the most effective actors will probably be in health will be almost certainly the Global Alliance for Vaccines and Immunization, probably in some respects, number one. The Global Fund to Fight TB, AIDS, and Malaria, number two. Certainly UNICEF continues to be an important actor, but with nothing like the money of the Global Fund or Gavi. WHO remains a remarkably important actor. Jan's asked me to talk about that in a few weeks. But you have to remember that the WHO is a technical organization. It's a standard setting organization. It's an advocacy and research organization. It really doesn't have money and doesn't fund activities within these countries. Gates remains important, not necessarily at the country level, but by financing all kinds of research and scientific activities that will hopefully lead to better drugs, better diagnostics, and better vaccines. The World Bank is substantially less important than it used to be, along with some of the other development banks, but remains critical. You could probably say if those organizations survived and a lot of others disappeared, it wouldn't make that much difference. I think you could identify over time which organizations have most enabled countries to enhance the health of their people. And we'll talk more about that in a couple of weeks. I hope that's helpful. Jan, please go ahead.
Okay, so far I haven't listed any other questions. So are there questions by the students now? They want to pose live?
There's a hand being raised by Sjoerd Bosman.
Okay, Sjoerd, go ahead.
I don't have actually a question. I just adjusted my camera.
I see. Why don't you go ahead and ask one? Please, anybody else? My feelings will be heard. I'm very sensitive. And I'm only willing to arrange a internship or summer in New Mexico for those who ask questions. Somebody had one. Please go ahead.
I have a question.
Please go ahead.
What was your motivation to specialize this much in global health?
Okay, what I'm going to do, Marilyn, is I'm going to come back in the third part to that question, okay? I'm going to focus the third part on my own journey in global health and what lessons I would want you to take from that, okay?
Yes.
Okay, there's another question by Simona. So she asked, how does health coverage in the United States work?
So the short answer is it doesn't work, but let me give you the following. So unlike any other high-income country, the United States does not see health as a human right, does not see health as a fundamental human right. So it's organized the healthcare system as much as a business as it has organized it as a social good. The US has a very mixed system with, in principle, the system is set up on the basis of private actors, private hospitals, private physicians, which could be for-profit or not-profit. But it also turns out that government actors are very involved through services for military veterans, services for Native Americans, services for poor people, and financing of services for older people. So at the end, we have a system that's about 50% publicly financed and 50% privately financed. We have a system that does not, I repeat, that does not guarantee you are covered by insurance. Most people's insurance is linked to their employment. And like in Germany, the premium for your insurance policy is usually shared by the employer and by the employee. But unlike Germany, so in Germany, if you lose your job, they have a fund that pays your premium so you stayed insured. In the United States, this is not the case. COVID-19 has highlighted this. And in the United States, we have over 30 million people somewhere between 10, we have about 370 million people, but usually we're running about 10 to 13% of the population, which has no health insurance, not through the private sector, not through the public sector. And these are often people who are just above poor. They have too much money to qualify for the poverty schemes, but they don't have enough money to pay for health insurance. And insuring a family in the United States now could cost $12,000 to $15,000 per year, even for basic care. Finally, let me say the costs of care in the United States are uniquely high. I had a surgery some months ago, a simple, very common surgery, because an older surgery had worn out, shall I say. And while I was giving a talk to senior American military people, my old surgery wore out and I started bleeding. But happily, I recognized the problem. And when I finished the talk, I politely said goodbye and went directly to the emergency room where I used to teach. The cost of the simple, very common surgery and 3 days in the hospital was $60,000 US. Luckily for me, because I'm covered by the Old People's Public Scheme and the World Bank's private scheme, luckily for me, I paid nothing. But if I had not been so lucky, I just would have gone bankrupt. I would have declared bankruptcy. The easiest way to get away from healthcare bills, you just legally declare bankruptcy. So the US, I repeat, has no fundamental commitment to universal coverage. It doesn't have universal coverage. Somewhere around 10, 15% of the people are uninsured. We have an extraordinarily expensive system, partly driven by the private nature of much of what goes on. And we don't really have now in the United States an agreement. We also have some bizarre things, which is if Trump gets his way and the Obama era Affordable Care Act is thrown out by the courts, we'll wind up with 60 or 70 million people without insurance, and insurance companies that are not obliged to cover you for illnesses that you had before. So it's a completely unique, chaotic, uncoordinated system that doesn't meet at all well the aims that the European systems have. And in addition, we spend 18% of our national product on this and live shorter than the Europeans live. That's my quick summary. I'd be happy at some time later if the students want to have an evening chat with me, we could talk more. It's really a mess. And COVID-19 has highlighted what a mess it is. We spend more on healthcare compared to Sweden and the Netherlands, probably for two reasons. So Betsy Bradley, who's now the president of Vassar University, is a really outstanding health management specialist and a global health person. Betsy wrote a very good book called The American Healthcare Paradox: Why We Spend So Much and Get So Little in Return. You in Europe have a social consensus. The Dutch more or less believe you're in life together, and therefore in the Netherlands and Sweden and other high-income countries, you have a lot of investment in trying to ensure that your young children are well-nourished, well taken care of, ready for school, and can become productive adults. In Europe, you spend much more on the social safety net and on the early years of life than we do in the United States. So we wind up with a less healthy population and having to spend more money on them. We also have, as you know, dramatically higher rates of cardiovascular disease and diabetes, for example, than you have. But the second thing is the system itself is one that's based partly on profit. And everywhere in the system, people are trying to make a profit. The insurers are trying to make a profit. And remember, the heads of our insurance companies get paid 30, 40, or 50 million a year. And the hospitals are trying to make a profit. Even when they're not-for-profit hospitals, they're basically making profit. It's just they have to reinvest it in themselves because of the legality of their being not-for-profit. So in addition to the fact that we are less healthy, we require more expenditure, and we have a profit-based system where everybody's trying to make as much as they can. And this, by and large explains why we spend, a third more than the Swiss and twice as much, 50% more than the Swiss and twice as much as almost everybody else, largely for those two reasons. What is the main goal of the US healthcare system? In a lot of ways, it's profit. You've not yet seen, Obama was pushing things in what I think is the right direction, but except for Obama, Donald Trump is not going to stand up and say, I really appreciate the chance to read Skolnik's wonderful book. And now I understand that as your president, my goal is to help enable the maximum health of America's people in the fairest ways at the least cost. That's your goal. I mean, it's easy for any European society or the Kiwis or the Aussies to articulate that their goal is the maximum health of their people at least cost in the fairest ways, which again in Europe means helping people live as long as possible, as healthy as possible, with the fewest disabilities, and spending the least amount you can in doing so. That's your goal. If I were the Minister of Health in the Netherlands and the Prime Minister said, Richard, help me to articulate in one sentence the clearest articulation of our goals, that would be it. In the US, nobody can articulate that. People like myself hope at least that if we change governments, that we'll have a government that would build on the Affordable Care Act, which you know is Obamacare, and that we will then try to ensure with an E that the remainder of our population is insured, and then do what we can to create a fairer system that begins to reduce costs. This is not going to be easy. When you think about the US healthcare system, you have to think about India or Nigeria, not about Australia, New Zealand, Sweden, or the Netherlands. We have a system that's much more like that of the Indians than it is like that of the Netherlands. So you say in the Netherlands, all hospitals should give the same quality of care. So Professor Nguyen would tell me if the word is should or do. I don't know any place where there really is the same quality of care, but it's a lot easier to provide the same quality of care when you have specialized hospitals in a country where everybody can get someplace. And I say this with great love for the Dutch, as you know. In the Netherlands, Professor Nguyen can run the infectious disease hospital in Rotterdam, and my friends in the South can still get there in an hour and a half by train or 2 hours by train if they have to. I was mentioning earlier, the state in which I live has is 600 kilometers north-south by 600 kilometers east-west. We have no water, it's very dry. We have lots of mountains, and we have very limited healthcare practitioners. So the answer is, look, in most countries, there's substantial variance in the quality of care. Look at studies from the National Health System in the United Kingdom, and you, like your British friends, will be quite disappointed. The Dutch may have less variance in the quality of care with Norway and Sweden than other countries, but there's probably some variance. The United States has enormous variance, and both what they do to you and how long you live has to do with what color you are, what occupation you have, whether or not you're insured, and the zip and the postal code in which you live. The single best determinant of how long you live is the postal code in which you live. And we have cities in the United States in which there's a 20-year difference in life expectancy for people who live on the same street 3 kilometers apart, okay? In terms of the quality of clinical care, my son, as Professor Nguyen knows, is an intensive care specialist, at the most famous hospital in the United States, one of their branches. If I get sick, I hope I live long enough to go see him and his friends, because I live in a small state that's poor with limited healthcare resources and no specialists. So the short answer is the United States almost certainly has the widest variation in the quality of care of any high-income country, both in inputs and outcomes, because it's large, it's fragmented, it doesn't have a national system, and it's a country which has enormous social disparities. You all have thought about this a lot, but you will be shocked. When you come to visit me, despite what you know, you will be both shocked and probably terribly disappointed. And for those of you who want to understand the US better, there's a new book I can send Professor Nguyen the name called Caste. Caste, the origins of our discontents, written by an award-winning author. And what she says is that, you know about caste in India, which is related to Hinduism. And so you understand the nature of Indian society still very much relates to the place that everyone has in society. This author looked at India, Nazi Germany, and the United States, and she suggests that caste and casteism continues to be the fundamental organizing principle of American society, and I have to tell you, I cannot disagree. So this is a completely, utterly different society than anything like what you see in Europe, and all of these inequalities get magnified in America. Does racism really affect healthcare in America? Completely, because racism affects everything in America. It affects where you live, and that has an effect on the healthcare you can access. It affects the job you have, and that affects whether or not you're insured. There's subtle, implicit, and sometimes explicit racism when people see you're a person of color when you show up in a hospital, so you might get different care, just like women might get different care. Yes, I mean, casteism and racism are a central part of American life, and they have a profound impact through access, social determinants, and risk factors. If you're poor and you live in a poor neighborhood, you might not have a supermarket in your neighborhood, and you wind up buying really crummy food that's high in saturated fats, high in salt, high in sugar from small stores in your neighborhood. And therefore, it wouldn't be a surprise if you see much higher rates of obesity in African-American populations, Native American populations, than you see in middle-class white populations. So understanding these disparities and inequities, understanding the relationship with America's original sin of slavery, racism, and casteism is central to understanding the nature of America and how different it is from anything like the Netherlands. And that's why I'm hoping, if, with all due respect to not mentioning politics, that if the wrong people win in America, I want to announce to you that Professor Nguyen has told me he will build a small addition to his house so all of my family can come and live in the Netherlands, which I really appreciate in advance.
Yeah, we're building at the moment, just to prepare.
Is there anything else on this, or should we move on a little bit to COVID-19? We're okay, Jan? Shall I move on?
Yes, I guess we should do that.
Okay, let me do this. Let me pull up 2 seconds. I'm going to pull up the slide set again. 2 seconds. Let me get down to this. Give me just 2 seconds, if you would. Now let me make a few remarks on this. Okay. There we go. So I just got to share, okay? Here we go.
Okay, so in the meantime, I have to take a call, so I will be away for 1 or 2 minutes, but I'll be
Okay,
back soon.
please go ahead. And Students, you can see the screen again, right? Yes?
Yes, it's visible.
Okay, great. So Professor Nguyen asked me to make some comments on COVID-19 and what it means for the study of global health. And I want to suggest to you, excuse me, that COVID-19 microcosm is an English word you probably know. It means a small sample of everything. And I want to suggest to you that COVID-19 really is a small sample of all things global health. And let me tell you why. First, this is a pandemic. Pandemic, the definition of a pandemic is a disease that's taken on, a certain level everywhere in the world. This is global, and by definition, we're living through a remarkable period that's intimately connected with all things global health. The second thing is fundamental to the study of global health is the study of the burden of disease and risk factors. And that is, what is it that people get sick, disabled, and die from? And why is it that this happens? Excuse me. This is two of Skolnik's famous 5 questions. And COVID-19, is having a dramatic and substantial impact on the burden of disease. First, lots of people are getting, 85 million people or something so far are getting infected with this disease. Second, a very large number of people have become actively sick with this disease. Many have died, and an important share of these people who live will wind up with short or medium or long-term disabilities. In the United States, COVID-19 is on track in 2020 for being the 3rd largest cause of death. And if we added, as you're going to learn about, measures of disability, it would certainly begin rising dramatically there too. So again, studying the burden of disease and risk factors is central to global health. COVID-19 is intimately related with that, and a wonderful or terrible reflection of all things global health in this regard. People who don't know much about public health or global health, and many people still, even in the face of COVID-19, don't understand the health development link. They don't understand the important economic, social, educational, and psychological costs that are linked to different diseases. Excuse me. In this case, it's unlike anything we've ever seen in modern times, really since the 1918 influenza epidemic. Normally, as you'll read about, the economic costs of a disease have nothing to do with the number of people infected. Normally, they have to do with fear. Mad cow disease cost gazillions of dollars in economic losses, but only 200 people or so died. Even SARS cost gazillions of dollars in economic losses, but in China, fewer than 2,000 people died of SARS. This is really different because not only are we seeing enormous economic, social, educational, and psychological costs directly related to illness, but the cure, in quotes, is shutting down the economy and trying to keep people distant from each other and try to do that as hard and as fast as possible in the hopes that you can suppress the virus and then return to more normal economic activity. So fundamental to global health is an understanding of the economic consequences of ill health. Fundamental to global health is an understanding of social issues and social determinants, the link between health and education, and the importance of overall well-being. This is all wrapped up here. And the other thing, and in a way, really, I can't think, polio is important. I'm old enough that polio was important when I was a young child. The vaccine came out when I was 6. But even at its height, you know, the polio epidemic in the United States may have had 45,000 people. So this is really extraordinary. You know, we're still in the United States running at about 35 or 40,000 new cases per day, and we're close to 1,000 deaths every day. And by the end of the year, by the end of September or so, we'll probably hit 200,000 deaths, which will make it the 3rd leading cause of death. So here too, it's just remarkably tied up with all of the global health issues we've been talking about. Equity issues, disparity issues, inequity, equality, these are all central concerns of public health and global health. And COVID-19, you know, has brought these out in a gigantic way. I'll use my own. So one way is the difference between rich countries and poorer countries, whereas the richer countries have much greater prospects for addressing COVID-19 than the poorer countries. 2, it's in what we think in terms of global public goods, which I'll talk about further. Is it okay if the rich countries buy up all the vaccines and the poor countries don't have it? Is it ethically okay? And is it technically sound? You will probably say it's ethically not okay. And technically it's stupid, because as long as the virus is circulating in other countries, it's going to circulate in the high income countries as well, even if you try to keep everybody out. So, but the other way this has raised equity issues is along the lines of some of your questions. In the United States, as I'm sure you've been reading about, the people most affected by COVID-19 have been people of Latin descent, our Hispanic population, and people of African American descent. And they've been, excuse me, it's not you, it's waking up at 5 o'clock. They've been affected, their rates of infection are substantially higher than the rates of infection of white Americans. And their rates of death are something now like 3 to 5 times higher than the rates of death. Why is this so? Well, I am able to work at home, let's say. But a Latin American immigrant who works in a meat packing factory in Iowa or in a fruit factory in California cannot work at home, works in close proximity to other workers, and those factories have become breeding grounds for COVID-19. They also live in crowded homes. They have less money to access good healthcare services, et cetera. COVID-19 also, as you know, has a special effect. People with underlying conditions, especially diabetes, are much more prone to become very sick. Well, for some of the reasons I mentioned, poverty, poor access to food, low levels of education, et cetera, the rates of diabetes, overweight and obesity in our African American population and our Native American population are much higher than our white population. And this is contributing to the disproportionate share of deaths from COVID-19 in those communities. And if you think about the lower income countries, let's say India, it's easy to imagine that better off people in the cities will have much better access to testing, diagnosis, isolation, contact tracing, and quarantine than the 700 million people who live in the countryside in India, you know, often living on $1 or $2 a day. So COVID-19, in some ways people might not have suspected, raises just gigantic issues on equity and on, you know, disparity. And then there's these array of issues as well, related to the global public goods. The spread of the disease is a global issue. The development of diagnostics is a global issue. The development of therapeutics is a global issue. The development of vaccines is a global issue. it's pretty clear that if countries work together to raise money to finance basic research, to finance translational research, to engage in advanced market commitments for the production of vaccines, for example, to arrange supply chain and distribution networks in advance, for example, it's pretty clear that we'll all be better off. But by contrast, my own country is going to go it alone. Americans have to hope that the vaccines that are being trialed here, for which the US government has put together some advanced market commitments, Americans better hope that those work better than others, or we will be substantially disfavored rather than substantially favored. So the nature of the problem is global. The nature of the search for drugs, diagnostics, and vaccines is global. The amount of money one needs is enormous. And it's pretty clear, both in terms of pooling scientific research, as well as in financing, development, production, distribution, that we'll be better off if we work together. And yet, as you know, this has become complicated, partly by the US approach, which some others have shared, to the World Health Organization. And that is regarding the World Health Organization as a slave to China rather than as a real international body. So just when we need to ensure that we're treating these issues as global and that we're all working collectively, the collective approach has really broken down in a substantial way, largely because of the behavior of the United States. And we'll have to see, who wins and who loses as a result of this. But it's easy to imagine that if we don't act very cooperatively, that the distribution of any improved diagnostics, therapeutics, or vaccines in low-income countries will suffer. And then the only way not to suffer ourselves, as I said, is to keep everybody out, which is very hard to do. So you may or may not know that just before the pandemic came out, there were two large studies of pandemic preparedness. One was done by Johns Hopkins University and the Nuclear Threat Initiative. Another was done by the Center for Strategic and International Studies. And these suggested that the United States was the best prepared to deal with the pandemic. And on paper, I repeat, on paper, the US was the best prepared. The US had the United States Centers for Disease Control and Prevention, which are the leading organizations, which was the leading organization in the world by multiples and multiples. I mean, in many respects, the US Centers for Disease Control and Prevention have been the disease epidemiologists for the whole world. And yet, the two studies failed to take account, as I mentioned before, of political will and ability and willingness to implement. So what happened is, led by Trump, we didn't have the political will. They appointed an incompetent director of the CDC, and the CDC has fallen completely to pieces. So COVID-19 has raised gigantic issues, and the Europeans, many of the Europeans, especially the English, as you know, did not do very well. It looks like history is going to suggest that the Swedish approach was completely mistaken and that the Swedish will be paying for it for a long time. And the Swedish economy, by the way, did not do better than the Dutch economy, didn't do better than the Norwegian economy, didn't do better than the Finnish economy, even though the Finns sought to suppress the virus and look a lot like New Zealand. So COVID-19 says, what's wrong with the world? Everybody knew this was going to happen. Everybody talked about what preparedness meant. We assessed even recently the extent to which different countries were prepared. We warned the world about gaps. And then it turns out there were these massive failures everywhere in the world. Look what happened in Italy initially. So certainly COVID-19 says to the world, the next wave is coming tomorrow. The next emerging or re-emerging disease is coming right down the road. You could have, this must be the best opportunity ever to learn. And is the world and will countries be smart enough to actually take advantage of this? I hope so. And then the last point I've kind of, touched on. So, I want to suggest to you that when you go through the chapters of the book, right? The global burden of disease and risk factors. And the other thing, if I may, is the relationship, I wanted to add this, sorry, between health system capacity and addressing the outbreak. So if you looked at Italy in the early days of the outbreak, you saw, even though everyone knew there would be emerging and re-emerging diseases, the Italian health system was overwhelmed. If you look at New York City, the health system was completely, utterly overwhelmed. So countries have increasingly strived towards universal health coverage. Part of what a health system has to do is prepare for pandemics and be able to address them in fair and evidence-based and doable and sustainable ways. And many countries have shown that not only were they not prepared in general, but that their health systems, even if they were supposed to have high capacity, weren't really able to deal with the surges of this. And we need to think much more carefully about the lessons of COVID-19 on the way that different healthcare systems are set up. I think, I'm going to stop there before I come. So let me stop there. Let me get out of this again. And Professor Nguyen is back. So Jan, I don't know if you were able to hear all of my remarks, but I tried. Let me just conclude by reminding you I started to, and I should have finished. I got up a little too early, but if you think, what I want to encourage you to do right at the beginning, just take a look at the table of contents of the book and say to yourself, burden of disease. What's COVID-19 say about the burden of disease and risk factors? What's COVID-19 say about the links between health, education, poverty, and development? What's COVID-19 say about critical issues in ethics and ethical investing in health and in equity and in disparities? What's COVID-19 say about the environment, climate change, and health, and the extent to which the world is going to be prepared to deal with some of the impacts of those? What's the relationship between COVID-19 and what we see in the chapter on health systems? Obviously, there's what's the relationship between, what about kids in COVID-19, women in COVID-19, special populations in COVID-19? I don't know about the Netherlands, but you don't have so many people in jail as in the United States. Part of our historic legacy is that we have very high proportions of some populations in jail. And as you may know, our jails became petri dishes for cultivating COVID-19, and where 70 or 80% of the people in some jails, both staff and prisoners, wound up with COVID-19, and some people, of course, died as a result. What about those relationships? Obviously, there's a relationship between infectious diseases. It's going to turn out that there's a relationship between COVID-19 and the chapter on non-communicable diseases, because some of what we might see is important after effects of people who've had strokes, people who've suffered neurological damage, people who've suffered cardiovascular damage, people who've suffered pulmonary damage, and some of whom will then depend on the relationship with the health system for either short, medium, or long-term care later on. And then even the chapter on humanitarian emergencies, I think, will be highly enlightening when you think about COVID-19, because it is a humanitarian emergency. And it's not just a typhoon or an earthquake in Pakistan. It's a global pandemic. So I want to suggest to you that as you think about the table of contents and you think about the topics on which you're going to focus, it's probably going to be helpful to think about COVID-19 and the way that COVID-19 manifests the most critical issues that you're going to study. And I think that will be helpful to your journey as you go about the course. Okay, Jan, I'm all yours.
Yeah, so there were two related questions. One from Nina van Pol. So she asked, which country do you think has the best approach to COVID-19 and why? And then this is something you addressed a little bit already. A lot of institutes are doing their own research to find a vaccine. Do you think there is a more effective way to find a vaccine or to combat COVID, for example, by working more collaboratively?
Yeah, so I'm a big fan of New Zealand. I recently tweeted in response to an article that I suspect that 10 years from now, if what we're learning about the possible health effects of COVID-19 infection become clear and turn out to be true, I tweeted that many Swedes 10 years from now will wish that they had lived in New Zealand during the pandemic. New Zealand, as you may know, is a spectacularly beautiful country. It's very well organized and very well governed right now. And one of the best tweets in response to mine was, Richard, I agree with you, but almost everyone in the world would like to live in New Zealand. So on the serious side, look, New Zealand's a small country. It's only got 7 million people or so. It's well organized, it's well governed. They have an important minority population, but still they have a strong sense of social cohesion in New Zealand. They have a strong sense of purpose. And I think we have to give the Kiwis a lot of credit. Korea is very homogeneous. It's relatively small in population, in size, big in population. It's got 60 million people. I think we have to give the Koreans credit. Taiwan is small in size, medium-sized in population. I think they're about the same size as Australia. I think probably the three countries that might have had some important advantages. One advantage was they'd suffered through SARS and MERS. But the other is, look, they're well-organized countries. The deputy prime minister or president of Taiwan was a public health graduate of the Johns Hopkins School of Public Health, which should have helped. So my three favorite places are Taiwan, Korea, and New Zealand, because from the first knowledge of what was going on in China, they just organized their countries to take classic public health approaches. Let's present clear and consistent messages. Let's have the leadership of the country bring everybody together. Let's devote whatever budget we need to addressing this as if our life depended on it. Let's follow classic public health work. Let's identify people with the disease as fast as we can. Let's isolate those people. Let's trace their contacts and let's put their contacts into quarantine in the hopes that we can suppress the virus. Let's engage in mask wearing and social distancing with a really strong force if we need to, or to the extent that we need to, so that as rapidly as possible, we can stop that and return to normal economic activity. I think the Kiwis, the Koreans, and the folks in Taiwan have probably, as well as other, I think the Finns have done a very good job. The Aussies have done a good job also. Those are the countries to which I would look. I write articles, like Jan has seen them, he can share them if he wants. I've been writing almost weekly articles on COVID-19, and some people here reject any comparison between the United States and any other country. But let me say this, the first infection in Korea and the first infection in the United States occurred on the exact same day. And your risk of dying a COVID-19 death in the United States is 60 times greater than in Korea, okay? So you decide for yourself where, when it comes to COVID-19, where you'd rather be and which country provides better lessons. So again, I would look at Korea, Taiwan, and New Zealand, which everybody knows, Australia, maybe Finland, the Icelandics. Iceland is special because they have a DNA registry of every Icelandic in a country that's only got 200,000 people, but they've done some very good work. I think these are some of the countries from which we can learn a lot. And then we could look at some others. The Germans, I think, have taken an interesting approach, and for a big high-income European country, apparently their experience has a lot to say for it. My own state, it's interesting here. So one of the questions, of course, is if you're looking at the all-in cost and benefits, what measures did they take, and what were the costs on the economy? If you look at the state in which I live and the state in which my son lives, we have a very forceful, left-leaning governor, and New Mexico took very early, very dramatic steps to address COVID-19. And we had to, because we're also a very poor state with a very large Native American and Hispanic population. The state next door, which has a large Latin and Native American population, is much more conservative, run by an extremely conservative governor. Our governor had been the Secretary of Health in New Mexico. Their governor was the chief operating officer of an ice cream company. You look at the two, and what you see is not only we took stronger measures to tamp down the economy, and they let the economy, they let people continue to go for haircuts, spas, gyms, restaurants. What they did was wind up with 10 times the number of infections, 10 times the number per capita of deaths, and the economic growth in New Mexico was higher than in Arizona, despite our poverty, because of the way we managed the outbreak. And I think history will have to look at the measures that countries took. They'll have to look at the all-in costs and the all-in benefits. But those are the countries, I think, which have important lessons. Look, the United States, just a couple last comments. The United States is a large, complicated federal system. The federal government has some rights and responsibilities, and the states have other rights and responsibilities. Donald Trump wanted, this is speculative about politics, but I think evidence historically will say I'm right. Trump did not want to take responsibility for federal coordination of the outbreak, even though that is the historic role of the federal government. Trump has also completely politicized everything scientific and appointed completely incompetent people to important positions. So what Trump did early on was said, I'm going to have nothing to do with this. If you have lots of cases in New York, don't blame me, blame your governor. If you have and initially this was easy for him because initially the outbreak was completely urban and in the largest, most urban states, all of which are run by people in the other party. As the epidemic shifted to being more widespread in the United States and having the largest pockets in Republican-led states, while the Democrats did a pretty good job holding it down, Trump was a little bit stuck, but by then he had taken the position, this is not my epidemic, this is your epidemic, and I can give some help, especially to those in my party. So the fundamental issue is, look, the federal government of the United States basically washed its hands of the normal coordinating role, without which in the United States, you had complete chaos. You had each state seeking, for example, to buy personal protective equipment on its own. Each state, for example, fighting with other states to get remdesivir when it was approved for emergency use. So I think history will say the fundamental issue was the federal government's walking away. that was made worse by the worst case messaging in public health history, led by a president who said over and over again, this is no problem. In 15 days, it's going away. Not only do I not need to wear a mask, but in addition, I'm inviting people to the White House to sit next to each other without a mask, okay? By the failure of the US federal government to implement the Defense Production Act, which can force firms to manufacture drugs, diagnostics, vaccines at a certain price. And then by appointing people, quite frankly, you would probably regard as insane. People who believe in conspiracy theories, who aren't well trained, who don't accept any evidence, and who believe that the pandemic is a hoax. We're not that different from Bolsonaro. We're not that different from Lukashenko. The only thing saving us is some states are led by enlightened people in a federal system. And although it's been difficult to coordinate, how's New Mexico with 2 million people going to buy personal protective equipment when California has 22 million people and can pay more? So this has been I think if you say, here's the epidemic, what public health measures should have been taken? I think history will record that the US under Trump did exactly the opposite in all of the classic ways, in a manner that led to hundreds of thousands of millions of needless infections and countless needless deaths. And the only way I can judge is by outcomes. Korea and the US had the outbreak on the same day. What measures should the United States have taken? To what extent did it take them, and what was the result? And the result, quite frankly, is a complete and total disaster. And we don't know when it's going to end. The last thing I'll say is probably you've read, the big fear now is that the Trump folks will politicize vaccines. They will force the US Food and Drug Administration to authorize the emergency use of a vaccine 2 weeks before the November election, before the clinical trials have been completed. And all of you should be deathly afraid of that, because if Trump does that, it will dramatically reduce confidence not only in a COVID vaccine, it'll reduce confidence in every vaccine, because more and more people will wonder whether or not the vaccine was ready for use or was just being forced to try to win an election. Almost everyone in the scientific community in the United States is now terribly frightened that the Trump folks will push through the authorization of this vaccine, that this will forever after reduce confidence in vaccines and leave us much worse off. Let's see, is there any other one on COVID before I take a 3-minute break?
I think one question, I asked
cooperation.
It's about cooperation, and specifically for within Europe, I guess. So you say the US is a federal state. Of course, the European Union is different, but also their collaboration was clearly lacking in the sense that every country took its own measures. So perhaps you could comment on that.
Yeah, I am not, I know much more about low-income countries. I've been to the Netherlands about 20 times, but really just as a visitor and friend of the Dutch. I worked on India for 15 years. I've been in there, almost every country in Africa. But my appreciation is that, indeed, as you've suggested, that cooperation in many ways was also lacking across Europe. And, all I can say is, right now, I think the Europeans are cooperating more, and all of the Europeans and almost all the rest of the world have now joined in an effort that's thinking about the ethical and equitable distribution of vaccines that are affordable when such a vaccine is produced. I think it's really only the US that's going to be outside of that. So I think it's getting better, but I think especially with the disease that emerged, about which we knew so little, I would have hoped that cooperation would have been first, second, and third on the agenda, because the problem was enormous. The cost of fighting it was extraordinary. The need to be organized and take a common approach was really critical so that people didn't exploit the loopholes. And I think the world in lots of ways failed pretty miserably on this, but I think the Europeans are moving in better directions now than the US. And let me just give you a frightening example of what happens in a place where there are different approaches. So my son, as I mentioned, is an intensive care specialist at the Mayo Clinic in Arizona, which is a branch of the famous Mayo Clinic in Minnesota. They produced ethical guidelines for the treatment of COVID-19 patients and what to do when you ran out of beds and you ran out of ventilators and you ran out of equipment. As those guidelines were supposed to be the same across all the hospitals in the state, but they weren't quite the same. And as patients became very ill, let's say my grandfather went to hospital X, and they said, well, we're really sorry, but grandpa's gonna die and we don't have any space, so we're sending him home. But the family heard that the guidelines were not being implemented quite the same way. This isn't the Netherlands. So what do you think they did? They took grandpa not to the hospice to die. They took grandpa to hospital B. And they said, grandpa's really sick and grandpa needs care for COVID-19. And they shopped hospitals. So within most of Europe, your systems are coordinated enough that that's hard to imagine. But here we have such fragmentation. But again, this highlights the importance of taking coordinated approaches across large areas and then messaging very, very, very consistently and very carefully. Let's see. Last thing I'll say is, look, I don't think the world has paid enough attention to COVID-19 in low and middle income countries. We have to assume that they lack almost completely in the poor countries the ability to address COVID-19 effectively. People are already living on the margin, and shutting the economy down is, almost impossible to imagine as well. So, I think the only thing we can hope is that some enlightened leaders, and Rwanda is one of them, in Africa will help show the way for other poor countries, and that this thing will end as rapidly as possible in high-income countries so that we can devote more of our attention to the universality of this problem. And as I said, the fact that if the virus is still circulating in India, the virus is still circulating in Pakistan, the virus is still circulating in Nigeria and Congo, you're not going to keep it out of the Netherlands or the United States. So I don't have an easy answer for this. I think it's a really very, very big problem. The last thing is, and we'll talk more about this. Look, do I think that the WHO is a hostage to China? No. Do I think that Dr. Tedros, the Director General of WHO, did as good a job as he might have in showing complete scientific impartiality while still being diplomatic? No. Do I think the US was ridiculous to leave WHO? Yes. Do I think it's stupid for Taiwan not to be included in WHO? Yes, they should find a way. There's a lot to learn from Taiwan. They also have an excellent health system of universal care. So it's just the last thing. Look, as all of you know, and when you go out and work in other countries, you'll master skills. if Professor Nguyen was the Minister of Health in Liberia, he would say, Richard, thank you again for coming to our wonderful country. We love you. We think of you as one of Liberia's best friends. And we thank you for going all around the country, looking at our tuberculosis project, which the World Bank has helped to finance. And we can never thank you enough. You know, we repeat how much we know you love Liberia. And I, as the minister, want to ask you, Richard, to please brief me on the findings of your visit. Now, Liberia is a very poor country. I love deeply. I've worked on it a long time. It's miserably incompetent institutionally. It's very corrupt. And although they've done some really good work, this is a really difficult challenge. So you could be sure, let's say, that they were only meeting 50% of the objectives of the project. Well, I don't turn to the Madam Minister and say, Madam Bonga, Madam Minister, well, let me be candid with you. Your country is terrible. Your health system is pathetic. Your approach to TB is not working at all, and your people are dying, and you're the minister. What are you going to do about this? No, what do I say? And here you have to think in French or Spanish. I say, Madam Minister, let me begin by telling you what an unbelievable honor it is to be able for the 4th year in a row to be working with a country I love so much. And let me thank you again for the chance to come here and work with you and your colleagues who are so devoted to making Liberia a better place. And Madam Minister, this is your country and not my country. And of course, I can't really comment on our findings. But if you insist, Madam Minister, perhaps I can, with your colleagues, present you with some of what we together found when we visited the field, knowing of your desire to do everything you can to make life better for your people. That's what you say, right? So you got Donald Trump and his friends don't understand how the world works, right? They don't understand that Dr. Tedros has to say to Xi Jinping, Mr. Prime Minister, China is a great country for which we have great respect. And we can only admire the remarkable ways the Chinese have tried to get rid of this epidemic. Of course you have to say that. And I think some folks don't understand this. On the other hand, I think WHO diplomatically, politically, and technically made some mistakes. I think Dr. Tedros did not keep the messaging on track. Occasionally they said some really stupid things. They let some of the world think they were in the back pockets of China rather than helping the world understand you must be diplomatic, but still be honest, etc. So I think we need WHO desperately. We especially need them now. I think they made some mistakes, but that's no reason to throw them out. So Jan, with your permission, why don't I take one last 30-second break and then we'll end with about 30 minutes on my journey. And more importantly than my talking about myself, I'll try to talk about what lessons I would want your students to learn from my own experience, okay?
Yep. Okay.
Take a 2-minute break and I'll be right back. Okay. Share screen again. Jan, I can't see you, so you're welcome to tell me when to begin.
You want to start again, Richard?
Sure, I'm ready. Is everybody else?
I hope so.
Okay.
There was one question remaining from the last session, which was, could you address, but you could do that later on very shortly, perhaps, on the Dutch COVID response.
Yeah, why don't I? So I don't, I've tried to keep up because I've tried to do some writing on this, and I've been involved, along with my daughter, who's a global health person, up here in New Mexico, with reopening of schools and houses of worship. I do track the data on some countries. I was following the Netherlands, but not so closely. My impression is that, and Professor Nguyen knows 5,000 times better than me, was that the Dutch initially set out possibly with some notion of seeking herd immunity, and that they wound up with an approach that was a little bit closer to maybe the Germans than to the Swedes. I'm going to be very interested in what happens with people who are infected and the extent to which we find out infection, even sometimes among asymptomatics, can lead to short, medium, or long-lasting disabilities. And to meeting Professor Nguyen and others 10 years from now to write the history of the different responses and what we learned. But Jan, so I'm not competent really to comment on the Dutch approach, but my impression was that it started out veering somewhat toward the Swedish approach, but then became more like the approach of some of the other Euro countries. Is that
No,
a fair statement?
that's correct. Yes, yes.
Okay.
There were discussions about getting herd immunity, but that never happened. And very quickly, it was more like we have to know where the transmissions are, where the cases are, contact tracing, testing, all these kind of things. So it moved more to like a German approach.
Right.
But,
That was my sense, and I
Yeah.
try to keep up a bit. Let me end with just a few very brief remarks. And this isn't because I like talking about myself, because I don't really. And I can imagine, Jan, that you'll have 96 Dutch students seeking psychological counseling after this session with Skolnik. But it's very great. You'll all have to ask, Doc. There we have a joke about the mother who slaps the child, slaps the child, slaps the child again, and then says to the child, "Someday you will thank me for doing this to you." And I think that's probably some of what Professor Nguyen is doing with you today by forcing you to sit through this with me. And I learn a lot and I enjoy this enormously, but it's only out of my affection for all things Dutch that I have 3 hours this morning to do this. So let me end with a few comments, as Professor Nguyen asked me to, about my own journey. I'm just going to talk about the journey for 2 minutes, and then I'm going to talk about the lessons for another 10. I was 16 years old. I was in the state of Ohio. I had never left home. My parents were nice people. They'd never been to university. They were not well-off people. And I applied to become a high school exchange student. I was accepted, and my first airplane ride was from Dayton, Ohio, to the northern Philippines via San Francisco, Wake Island, Manila, and then Lawag in the far northwest of the Philippines. This handsome young man you're looking at now is me in 1966. As you know, the Philippines has a strong musical tradition, and I was a serious folk singing type. I think I was selected because I could sing and play the guitar, selected to go to the Philippines. And I was extraordinarily lucky. I had, as an exchange student family, the best exchange student family in the history of the world, with whom I'm still very much in touch. And I had the most wonderful exchange student experience in the history of the world. And I decided that summer, living with a Filipino family, that there were lots of poor people in the world, that there were important needs to make their life better, that the role of an outsider in this might be limited, but I should do that. And initially, I wanted to be like Professor Nguyen and like David Heyman. And then, respectfully to those of you in medical school, I said, anyone can be a doctor. There's this new business called development, and I'm going to focus on the broader aspects of human development, health, and education. And so, unlike most people, from the time I was 16, I had a completely singular devotion to becoming a development person who worked on health and education to try to make life better for poor people in poor countries. I was very fortunate. I went to Yale University, which is a very fine university, and they had a program for sending people away for a year. And I went back to the Philippines, lived with the same family, and taught biology and general science, and further cemented my interests. And then Yale had another program that sent people to Hong Kong for 2 years. So when I graduated, I was selected to go to Hong Kong for 2 years. Hong Kong was still poor, if you can believe it. There were rooftop schools. My wife grew up in a small village house. It was probably 7 meters by 7 meters with 7 people in it in Hong Kong. And living there and learning Cantonese and bad Mandarin further cemented my interests. And then I came back and did a graduate degree in public policy and development at at Princeton. So my journey is unlike most people's. If you're in medicine, maybe your journey will be similar, but it's not everybody has an experience as a 16-year-old that transforms their life forever. But one thing that's important is, since, and then I went from the Woodrow Wilson School to the World Bank. I decided when I was 50, I had loved my work, it couldn't get better, and I should seek other things to do while I was still young. And I transformed myself from being a global health practitioner to being a half-time global health practitioner and a half-time global health educator. But there were no materials when people were just getting interested, so I wrote the first version of the textbook. And then I more or less continued to be a part-time practitioner and a part-time educator until 5 years ago, when I really became a full-time global health educator. And now I'm a global health educator and an advocate for global health. And I'm very involved in a number of global health activities and COVID-19 activities, now in my own country for the first time. What the lesson of this is I'll talk about is, don't get too excited about knowing exactly what you want to do and believing you will do it your whole life, because you won't. Remember, when I was in graduate school, there was no HIV, but I spent an important part of my life working on HIV. There was no vaccine for rotavirus or pneumococcus, but I spent a large share of my life working on childhood vaccines. There was no question about universal health coverage in poor countries, but I spent an important part of my life working on universal health coverage in poor countries. So in America, it's the best universities. The students think they have to know exactly what they're going to do, and it's forever. You don't need to know exactly what you want to do, and it's not going to be forever. You have to gain the perspective and frameworks and interests and commitment that will allow you to change with time, to do different things over time, to make the world a better place, even if they're primarily within medicine or primarily within another field. Let me end with, and Professor Nguyen should repay me for these valuable lessons by shipping me maybe a dozen Pannenkoeken, Professor Nguyen. I really like Pannenkoeken. If you could send me a dozen of them, perhaps my family and I could enjoy those as a partial repayment for the $1 million lessons I'm now going to give your students for free.
Perhaps the students can bake them for you when they arrive in New Mexico.
The students can bring them when they come. So let me begin by saying, if I only had 5 minutes with you, what would I tell you as you start your journey? Number one, focus on outcomes, 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 and outcomes. You don't care if a patient gets treated for tuberculosis. You care if a patient gets cured of tuberculosis. And yet a huge share of our health and development work has focused on inputs rather than outcomes. We need to worry about inputs. You can't have outcomes unless you have inputs and outputs. But don't focus on them. Focus obsessively on what you're after. When I worked on education, no one had a clue if the education investments were worth anything, because they were not measuring their impact. I'm still proud that I worked on the first project in the World Bank to measure whether or not an education project improved learning outcomes. If you're working on a program for improving healthcare in Guatemala, set some metrics for what you mean by improved healthcare or improved health outcomes, and then obsessively measure progress against that. The most important thing I can tell you, and actually the same thing if you're a clinician, my daughter went to the most famous foot surgeon in America. After surgery, he said, "Oh, your incision looks good. You're good to go. You can go back home." And she said, "Don't you want to know if I can walk?" This was the most famous foot surgeon in America. and he could absolutely not spell the word outcome. By contrast, my daughter is a big footballer. She played for the small college national champions. She tore both of her anterior cruciate ligaments, but she went to an orthopedic surgeon to fix those, who said, Rachel, my goal is for you to play again on a national championship team. We will measure your outcomes every so often against A, B, and C. So whether you're in medicine or not, whether you're in health and development or not, I can't, there's no more important lesson. Focus on outcomes, outcomes, and outcomes. Number two, planning, as I mentioned, is easy. I can write the best. Give me a topic, I'll write a great plan. I'll give you a topic, you'll write a great plan. What you really need to ask yourself is, what will it take to implement that plan? What will the bottlenecks be? Where do we need people? Where do we need skills? Where do we need money? Where do we need monitoring? Where do we need evaluation? This is absolutely central. And yet the development community spent much too much time, in my view, talking about plans, talking about inputs, and not focusing nearly enough attention on outcomes. Three, there's no substitute for data and evidence. You have to let outcomes drive everything. Let evidence drive your understanding of whether or not you're getting to those outcomes. And to do that, you have to measure, you have to measure, you have to measure. And you get what you measure. I worked on one country that's famous for gender disparities. And when I worked, including with my Dutch friends, we asked them, when we saw the tuberculosis register, why no women were getting tuberculosis. And they said, oh, you know, in this place in the world, women do not get TB. We assure you, Richard, we assure you, Jan, women do not get TB. Well, when we worked with them to change the registers and talked about the extent to which in the future we would all be looking at their identification of women with TB and their treatment of women with TB, suddenly women in that province and women in that country started showing up in large numbers with tuberculosis. If you don't measure whether or not women, if your TB program doesn't measure differentials by sex and doesn't have measures for women, in countries that don't care about their woman won't get sick, except they will and they'll die. Start at the end, let outcomes drive everything, focus on implementation, measure the right things, ensure you get good data and evidence. And then honestly, I would encourage you to be sure that you independently verify. Everybody's got biases, and yet most institutions have always let their own people measure whether or not things are working. I am a gigantically big believer in independent verification, independent audits, independent monitoring, independent evaluation as far as possible. If you think about our schools right now, they're going to open physically in a few weeks. They have a checklist. They're supposed to reopen when they can meet that safety checklist. My daughter and I are strongly encouraging the school system to ask other people outside the system to be responsible for examining the checklist, walking through the schools, and determining whether or not they can actually fill the boxes. And then every month thereafter, doing the same. It's not because we don't trust people in the school system, but first, the school systems don't do public health. Second, they have an enormous amount to do to reopen schools. And third, it's always true that good independent evaluation is the best. And finally, remember two things, and I should have said ethics. Things don't matter unless they're ethical and fair and you achieve them at least cost. And achieving them at least cost is also an ethical issue. So one overlay on everything will be to ensure that there's an ethical overlay, that fairness is central to all that you do, but that the achievement of your goals at the least possible cost in fair ways is also driving these outcomes which you're obsessively measuring in data-based ways and trying to verify as independently as possible. And finally, sorry, in terms of career lessons, get skills. There's no substitute for skills. If you want to work in global health, there's no substitute for being a little bit of an anthropologist, being a little bit or of a lot of an epidemiologist, being a little bit or a lot of a sociologist, being a little bit or a lot of a clinician. To be effective, you must gain skills, and you must gain them at a high level. Why should people in India invite you to work with them if you don't possess the highest level of skills and you don't have the most exceptional global perspective about what we're learning about TB or malaria or HIV or maternal death, etc.? You need skills at the highest level. You need to be extraordinarily global in perspective. If you're in Europe, it's easier if you're here, but you still need to go beyond that. You need to get to the point where you have an almost automatic feel for the way Guatemala works, India works, Liberia works, Laos works. You need to be thinking and acting all the time in multidisciplinary and interdisciplinary ways. Public health and global health cross disciplines. If you want to worry about a plasmid or mitochondria, that's okay. But that's not okay if you want to work on global health in a big way. You've got to go beyond that to understand determinants, social determinants, and to be able to learn lessons across a wide array of areas. And you've got to be able to work in teams that are multidisciplinary. When I was at the World Bank, all of our teams were a project management person, an economist, an anthropologist, a public health person at a minimum. And you need to be thinking and acting along those lines and be able to work with people. I would suggest that you become broad in your knowledge of global health. So you have a really good broad perspective and an instinctive feel for the key issues in global health and what can be done about them. But at the same time, find a few areas that you're really good at. There's just too much knowledge. There's too much information. There's too many topics. But you can't be narrow, in my view, if you can't be broad. So I would start by being broad, but at the same time, develop areas of special expertise, whether it's epi or it's women's health or it's infectious diseases or it's antimicrobial resistance or it's emerging and re-emerging diseases or it's not diabetes. Start broad, but have a few other areas at which you're good. The same is true for regions if you want to work on low and middle income countries. You need to know the whole world, but you need to know some places better. But understand that if you work in global health, okay, you really have to be able to work almost anywhere. This is not very humble in some ways, but the questions aren't that different. And the reason is if I'm running an organization, today I have a problem in Guatemala. Tomorrow I have a problem in Liberia. The next day I have a problem in Pakistan. And if my friend Carolyn has shown very good work in Guatemala on women's health, I tell her, look, Carolyn, I know you love Latin America, and that's your first and second and third love. But there's a lot you know that can be really helpful to my friends in Liberia. And we just won an award to work on Liberia. I really need you to work on Liberia. You can't say, I'm sorry, I only want to work on Latin America. I'm sorry, I only want to work on Asia. So you need to get into some region or regions at greater depth, but you have to be able to work all over. And that means being able to work with a wide range of culture groups in a wide range of circumstances. And let me say this to you at the early stage of your career. I hope you appreciated what I've said to you today. If so, 99% of the value of what I said has come from the experienced people with whom I work. My former senior colleagues are 85, 86, 87 years old. When I write an article about COVID for the newspapers, I send it to my 87-year-old former boss. I send it to my daughter too. I can't, in medicine, there's a well-practiced approach to mentorship in internship, residency, and fellowship. But I want to tell you, if you want to work in global health, find experienced people early, find people smarter than you early, find people early who like to adopt nieces and nephews, and learn as much as you can and make that learning a continuous part of your journey. Because I can only repeat, much of what you become will depend on the people from whom you work and learn. Jan, I hope I've met your aims. I'm happy to take a few more questions about the lessons of my own experience, if you'd like.
Yes, thank you so much, Richard. Always very good to hear you, to see you. Are there questions relating to this career path, working in global health part?
I'll still be, I'll be even more insulted if you don't ask. Let me just say two last things, which were in part of the other thing, if I might. I mean, this is something on which Dutch people are extraordinarily good. But one is to work effectively in global health at any level, but especially as you move up, you need to be able to articulate very well, both in writing and orally. And you need to be able to do that with a range of different culture groups. Knowing a lot doesn't matter if you can't communicate effectively. Knowing a lot doesn't matter if you can't approach multidisciplinary, multi-country teams with humility and work well with other people across these different culture groups. And so, you know, when I taught at Yale, we have a standardized test in America. And, you know, every Yale student gets like a perfect score. And they put this on their resume, on their curriculum vitae. And I would say to my adopted Yale nieces and nephews, I would take their resume. Oh, you know, Anne May, I would say, don't mind me, Anne May. I would say, oh, Anne May, as your adopted uncle who's helping you in your career, I'm going to take your resume and I'm going to tear it into 100 pieces. Because you know what? I don't care if you got a perfect score. Because the truth is, when it comes to global health, you're 19, you don't speak 5 languages, you haven't been in 26 countries, you don't know David Heyman from Jan Nguyen from anybody else. You have no understanding or appreciation of the critical issues in global health and what can be done to address them in ethical, cost-effective, doable, and sustainable ways. What I can tell you is you're a highly intelligent young woman with a great heart who wants to make the world a better place. Now, if you do the right things and gain the knowledge, skills, and experience that you need, then Uncle Richard, 20 years from now, will take great pride in your leadership in the world of global health. But if you think that because you got a perfect SAT score, that you're going to run the world of global health, it's not going to happen. So one needs to possess these range of skills, think about how you want to make the world a better place, and then say, what's the knowledge, skills, and experience I need to get there? And how do I get those? And what kind of really intelligent, talented, committed, successful people can I learn from in order to get where I want? And that's why I have 2 career chapters in the book, so that you can read about people you might want to be like or who will inspire you. Jan, is there?
Yeah, there are some questions. So
Okay.
one question is, when did you meet your mentors? What point of your career did you?
So, you know, really, throughout my experiences from my first visit to the Philippines, I realized when I got to the Philippines, I was living with a family with a very wise exchange student mother and father. And for all the rest of my life, until she died last year, she was really quite in good health. And if you can believe it, you know, as a 70-year-old American, I was regularly discussing issues with my 98-year-old Filipino mother. And then I have a number of friends who are classmates and things who are really talented. They've done very well professionally. And I've kept in touch with them and continued to learn from them. In graduate school, I clearly had a mentor, and as I mentioned, he was one of the pioneers in human capital economics. And then I got to work with his son, which was very touching and a great joy. And he had a profound influence on me as long as he lived. And then certainly at the World Bank and beyond, I had colleagues, some junior to me, but some the same as me, some senior to me, who I realized were people I could learn from and should learn from. So, you know, one might have said that Rick, let's say Rick was working on Latin America, and I heard that Rick had done some really interesting work on insurance in Brazil, and was just the best person on insurance. I would call him and say, Rick, you know, maybe I'm older, maybe I'm a department director, but how about letting me adopt you so me and my colleagues and I can learn from you? So I'd say at each stage of your journey, look for people from whom you can learn and continue to treasure them, you know, throughout. That's what I would say. I mean, David Heyman, Professor Nguyen knows, David Heyman and I work together a lot, but I'm very much in touch with David. When I write articles now, I often send David some of what I'm writing or the whole thing and say, David, you know, tell me if I'm right or wrong about this. I'm very fortunate that I got to work with people of such remarkable talent, but they're everywhere. And the former health sec, I have a number of people, I worked so long on India, for example. I have a number of people in India I consider to be my Indian aunts and uncles and people who are my mentors. I have a couple of really dear friends in Liberia, and we have a kind of mutual relationship. When they're writing something for the president, sometimes they send it to me and say, baby brother, the president wants this by tomorrow. And we all decided baby brother Richard should comment on this for us. Please do so in the next hour. You know, your grandchildren will forget you. And then I might send them something and saying, you know, Othello, I'm writing something about Africa, and I don't want to give this to anyone else until you've seen it. At every stage of your life, I encourage you to identify people from whom you can learn and stick with them and keep learning and keep identifying such people. What's the most interesting thing I've learned about global health in my career? Wow, that's a challenging one. You know, I mean, I think the most interesting thing that I've learned is the lessons of positive and negative experiences. And don't forget, there's a lot of lessons from negative experiences. As Professor Nguyen knows, you know, in the 60s, the world tried to eradicate malaria and then gave up. Well, anybody who's working in global health should understand those lessons. So broadly speaking, you know, I think the most interesting thing I've learned is to focus on the lessons of both positive and negative experiences. But at the same time, honestly, I think the most important thing also is learning more and more as a non-scientist, but as a policy person, to focus on outcomes and evidence, outcomes and evidence, outcomes and evidence, outcomes and evidence. And don't let anybody move me away from the focus on the achievement of outcomes, which we hope to meet on the basis of the best evidence and measure on the basis of the best evidence. I think those are the two most important or interesting things I've learned. Anything else, Jan, or anyone else? If not, let me.
There's one question which is more like future perspective. Do you think, perhaps I can translate the question into, do you think there will be an ideal world where everyone will live according to the WHO definition of health?
You know, I think we have to hope that the world will continue to make progress, but we have to be inspired both by that hope and by the terrible circumstances in which many people live. You know, people often say to me, how do you run around in all these poor countries? Don't you get depressed? Don't you just want to do something else? And of course, the answer is absolutely not. The answer is you need to be optimistic all the time. You need to see that we made important progress, but you also need to take inspiration and hope from the terrible circumstances in which so many people work. I'm hoping that we will learn from COVID-19, that we will see this as a wake-up to further enhance our knowledge of global health, our commitment to global health, our ability and interest in working together, and we'll overcome some of the losses from focusing so much attention on global health. But I would be wrong if I didn't say, look, this is going to take a long time. For those of you who know Pakistan, for those of you who know India, for those of you who know the life of indigenous peoples in the Andes or in Central America or in the United States, for those of you who know the life of sharecroppers, people without land in the Philippines, or people in Western China, there is a long road to go before we live in a world in which people all meet Professor Sen's hope of being all that they can be. I think we have to work hard to do that. I think it's possible in the long run to achieve it. And I think the good news is we know largely what needs to be done. And therefore, a failure to enable more people to uplift themselves is a political failure. It's a failure of will. By and large, it's not a failure of knowledge. Kids don't get immunized in Congo or Ethiopia because we don't have good vaccines. They get immunized because there are inabilities to implement immunization programs effectively, or people who don't care about immunizing their poorer children. And that's what we really need to overcome. And that's why, you know, I've always been heartened by the approach of the Dutch people and the Dutch government to development issues. And I hope when COVID-19 falls a little bit, we'll continue to see the Dutch, you know, trying to lead the world in good directions. And I'm hoping 10 years from now, Professor Nguyen, if he's still my friend, if he's still willing to have me as a friend, will tell me about all the great things you're doing. Is that, so with that, I can't thank you enough. I always learn a lot when I get invited to do these things. I always have to confront some of my own realities. I'm especially grateful, and I actually would not do this for people in many countries because I just got too many things to do. I hope that this has been both value adding to you as well as a little bit inspirational. And I look forward to hearing from you and from Professor Nguyen about the many wonderful things I'm sure you'll achieve, both in your own countries and in the world as a whole. So Professor Nguyen, I'll be in touch with you about the 22nd and the 15th and 22nd. But I hope that I helped you to achieve some of your aims today in a way that won't lead all of your students to substance abuse disorders.
No, thank you so much for joining us again. Very inspirational, at least to me. I hope for the students as well. I already got some posts by students who were leaving because of jobs and other issues and other things to do. So I think we call it a day, if that's okay with you.
Sure, no, the pleasure is all mine.
And we hope to see you soon. So thank
Pleasure
you
will
so
be all
much.
mine. Thank you very much again. Take care.
Okay,
Bye-bye now.
bye.
Thank you.
Thank you.